Tim, and welcome everyone. It's nice to be here with you again. Today is all about skin, reimagining our view of skin. Such an important issue. But first of all, I'd like to thank our support team, because without them, none of this could happen. You know, you see me, but there's a whole cadre of people that make this happen. We have our fearless leader, Julie, who does a terrific job. She's so wonderful. And we had Kaylee on our technical side, but Kaylee has moved on to a different position. And so we have Tim, who's here with us today, brand new. So welcome, Tim. And of course, we have Chris from the Paralysis Resource Center as our support person. So you see, there's just a lot that goes on in all this technology and all this coordination to make all of this happen. But today we're going to talk about skin. And, you know, people just need to be ever vigilant about their skin when they have paralysis or when they have immobility. If you have urinary or bowel issues, that can affect your skin. So just being careful about your skin is just critically important. Now, it's something that you need to think about several times a day, to look at your whole entire body and look at your skin and plan ahead about how you're going to do your skincare. Hopefully, and many people have no issues with their skin whatsoever. Sometimes they get thinking, well, I haven't, you know, I've been doing this for how many days, months, weeks, years, and I've never had a problem, so I don't need to do that anymore. But it's always lurking out there. Skin issues are always lurking. So some people don't have any problems at all, and then all of a sudden they do, for a whole host of reasons. And some people have skin issues just all the time, even though they're taking all the precautions that they can possibly take. So there's a lot of factors that figure into skin. Now, I will give you an example on myself. I do not have paralysis, but I am edging my way out back into society. So I got the chance to go to a friend's birthday party over the weekend in the park. Now, everybody knows me, and they know that I'm very cautious about the COVIDs even still, because I am immunocompromised, and we all have to re-enter at our own rate when we're comfortable to do this. But since this was a friend's birthday party, it was out in the park, I thought, okay, I'm gonna take the big leap and go into this crowd. Now, it was a small group of people. It wasn't really a crowd, but I thought, I'm gonna go ahead and do this. I'm gonna wear my mask, which I did. And these people all know me, and they know that I'm super cautious. And so they're all respectful of that. So, you know, we all had social distancing. I had my hand sanitizer with me, so all good there. But since we're going to be outside, I thought I really need to protect my skin. And so I had my big hat on with the wide brim that I just dearly love, because you can toss it into the washer. It's ventilated. Oh, it's just wonderful. It has a little link around the neck so it won't blow off in the wind. I wear it all the time outside in the sun. Had my sunglasses on, had my lip balm on, had all my lotion on, but I don't know if you can see, I got this horrible sunburn just right here along my arm. Now, why? I don't know. I took all the precautions. I tried to sit in the shade. I was out in the sun a little bit, and I thought, why would I get the sunburn just along this top portion of my arm here? And I thought, I don't know. I put the suntan lotion on there, and so I thought, I don't know why didn't it get on the rest of my arms? Now on my face, I could see because I had my big hat on, so that would be hard for the sun to get in there. And then I thought, oh, I know what it was. I had gotten a phone call that was important to me. And so I stepped away from the party, and I was on my phone, holding my phone. And when I held my hand as I was holding my phone, I thought, oh yeah, that's why the sun got right there. And I thought, now this is good notation for this webinar today, because I thought I took all the precautions. I did everything I could do. I thought ahead of time. I planned for everything that was going to happen, and still I got the sunburn. So it just shows you how easily, even with the best intentions in the world, you can still end up with problems on your skin for, you know, a variety of reasons. So I thought, let that be a lesson to me, because, and that's my message that I was hoping to get across with this last month's blogs was reimagining skin, your thoughts about skin, because you can be the best intentioned person and do everything just according to the books and still end up with some problems. Now I have a skin sunburn, so I've been applying some lotions on there that are help you reduce your sunburn and all that. And it's helped quite a bit. So that was kind of an interesting thing. I didn't feel this sunburn. I didn't even know I had this sunburn until I got home and somebody said to me, "Hey, you got some sun on your arm there in that one spot." And I'm like, "Oh, that's weird, isn't it?" It wasn't until I went to bed that night and I felt the sheets were rough on there and it was kind of sore, but not anything to worry about. But it just goes to show you that these things just happen. And so it's the same thing with pressure injuries. Sometimes they just happen. And it can be pressure injuries are just multifactorial. There's just a bunch of things that happen. You need to take responsibility for your skin. You need to take your actions, but you also need to know that there are other factors that play into life that you sometimes have no control over. So know about what causes pressure injuries. Know that you need to do your pressure releases. Know that you need to sit or lay on medical grade pressure dispersing equipment. So a lot of people, and I know I have seen this in facilities where somebody will develop, maybe they have sensation, but perhaps they've been laying in bed for a long time and haven't been able to move and turn because they have been so ill. And so it just hasn't, we all move and twitch the parts of our bodies where we have sensation. We do it thousands of times a day. But, sometimes people, they just, for whatever reason, they've been laying in bed and they get that sore on their bottom, the one. And right at the top of the gluteal fold, better known as the butt crack. I mean, so we all know what we're talking about. So sometimes people get that just from laying in bed on their back. And the reason is because they're laying on a hospital mattress. It has some pressure dispersion, but not for just laying there for hours on time. Or they've been sitting in the wheelchair. And so somebody says, "Oh, I know, I'll get them a cushion right now. I'll put a pillow in there." Pillows do not disperse pressure. They collect pressure. When you're on a pillow, you're just ramming your bones right in there and the pillow collapses and becomes hard. It doesn't spread the pressure out as in medical grade hospital equipment. So you just have to use that no matter what. You just have to use your medical grade pressure dispersing equipment. You can go to your therapist and you can have something done called a pressure mapping. And there's like a sheet. It's a little thicker than a sheet, but it's like a sheet that they put underneath you where you're sitting or where you're laying. And they can put up an image, an outline trace of your body. And then all you see are colors on there. And so if it's red, that means there's a lot of pressure right here. And it's usually under where the bones pressing up against the skin. And then it'll go to different colors if the pressure, as the pressure disperses out. You can look at that and say, "Oh, this is where I really have a lot of pressure." And then they can adjust your pressure dispersing equipment to be sure that that pressure is being spread out and not just concentrated right under that bone. You might see on TV, there's commercials for people getting shoes. Dr. Scholl's, I believe, has the commercial. And you can go and stand on a machine and it just your feet, and it'll show where there's pressure on your feet. So you buy the right piece of dispersing equipment for insoles for in your shoes. Now, that just gives you an idea of how this works for your whole body. I know some people can't stand and do that on the bottom of their feet, and nor may they need to do that, but that's the way this technology works. So it's very, very handy. So, you need to take responsibility doing your pressure releases, using the right equipment, getting good nutrition and good hydration to get your skin working well from the inside. And then also other factors can affect your skin. You can have hormonal changes. So sometimes when people get a little bit older, their hormones change. Women might be going through menopause. Men sometimes have changes in their testosterone, and affects how your skin is. Your skin can become dry. If you have a secondary condition of type 2 diabetes, if you get that from your immobility of having paralysis, sometimes people develop type 2 diabetes because they can't use their big muscles in their thighs enough to metabolize that glucose in their body. And so they develop that type 2 diabetes. That can really dry your skin and change the way your skin is functioning. So there's a lot of things that happen within your body if you have a fever, infection. Like I said, people just lay in the bed too long, or maybe they've been incontinent. And certainly things like having urine on your skin, which is caustic, having diarrhea, which is really caustic. Sometimes people sweat excessively when they have paralysis, and that's due to the autonomic nervous system, where there's just this flood of sweat. The autonomic nervous system, when you're having an autonomic dysreflexic episode, it's an all or nothing. It just shoots out all the energy through your nervous system. So sometimes that gets out of control and people just sweat horrifically below the level of their injury. Sometimes people sweat horrifically up above the level of their injury, but there are treatments, and I've written in the blog this last month some of the treatments that you can take, some medications, there's some lotions. Now, you don't want to clog up all your pores so that you can't sweat at all. A little bit of sweat is good for you because it keeps your body temperature regulated. So sweat will cool your body. Less sweat will keep your body warmer. And so you need, you don't want to remove all of that. The more sweat you remove from your body, the more it's going to be replaced in sweat. So you have a lot of the sweating coming out of your body. You might need to change your clothes, might need to change your sheets at night. We're talking about a lot of sweat drenching. So you can become dehydrated very easily. So these are all things that, naturally affect your skin. So, the thing about your skin is to check vigilantly about your skin. Always be checking. And it's critically important to be looking and checking. Take a photograph if you see any kind of change in pigmentation in your skin, because you'll want to know tomorrow what that pigmentation is like. Now, you may have a caregiver that's looking like at the backside of your body or at your heels. Get a long-handled mirror so you can look and see what your skin is, because sometimes caregivers get sick and they're not there and you don't know what it looked like a couple of days ago. The caregiver did, but now something's happened and maybe they got the COVID, all kind, who knows, their car broke down and they can't come, and there's all kinds of things that happen. So it's your body. You need to know what's going on with your skin. So very important that you look. And the second you see any change in pigment on your skin, especially over those bony prominences, so like right here, you can feel this bone sticking right out of your wrist here at the side of your wrist. That's a bony prominence. That's a place where you can easily get a pressure injury. Now, I can feel up my arm and I can feel my bone coming up here. It's not as pointy as this bone is right at my wrist, but I can feel that bone in there. If I had on a wrist splint and I had a strap that goes over that and was rubbing that area right there for some reason, I could develop a pressure injury. If my wrist splint was secured over here, I might get a pressure injury on this bone that's just not a bony prominence, but I could still get a pressure injury there. I'm going to just put some pressure on my wrist right here for a little while, because I have very fair skin, lightly pigmented skin. And so my pressure injury for me would look like a red, pink, sometimes even a purple area. Now, don't ever do this to yourself, apply pressure and give yourself a pressure injury. I'm not going to develop a pressure injury because I don't have paralysis there, but you can't really see, but it's kind of turned a little bit pink there. It doesn't really reflect well in this light, but there is a little pink there. If I had darker pigmented skin, I might develop a spot that looks kind of white. Sometimes people will call it ashy. just in this one spot over that bony prominence, or I might get a darker purple spot, some change in the pigmentation of your skin. No matter what tone your skin is, if there's a pigmentation change in your skin and you have paralysis, you're developing a pressure injury. Unfortunately, when you see it on your skin, that pressure injury is already well developed inside your body, because the pressure injury doesn't develop from the skin going into your body. It develops from that bone inside your body out to the skin. So it's often described like an iceberg. The iceberg, you'll see a little tip of the iceberg sticking out of the water, but there's a great big iceberg underneath the water where you can't see because that's heavier. And so you can't see that lower part of the iceberg. That is what you need to worry about, is what's underneath that skin. So wherever you have a bony prominence, most often people will have pressure injury on their sitting bones, the ischium, those bones that if you reach underneath your bottom, you will feel some bones from your pelvis that are now pressing up against the lower part of your buttocks. And people will develop pressure injury there. They'll develop pressure injury at the sacrum, which is the top of that gluteal fold. If they're sitting in their wheelchair laying on their sides, they'll develop them on their hips. And that's the most common areas to get pressure injuries. But you can also get pressure injuries on your shoulders, on your elbows, on your knees, on your ankles while you are laying on your side, or on your heels. Sometimes people will get a pressure injury right back here at the crown of their head, or at the base of their skull. You can feel there's a little ridge there. Sometimes people get pressure injuries on the top of their ears if they're laying on their side on a regular pillow. Sometimes people have to get a pressure dispersing pillow to lay on to avoid that. In surgery, if people have surgery on their back where they have to lay on their stomach, they're not very happy when they come out and they have a big pressure injury right up here on their forehead, or here on their chin, or on their nose. Now those heal up pretty rapidly because that's not a place where you usually put pressure. But so and when you're off the surgical table, it starts healing. But what happens, and there's those little capillaries inside the skin collapse with pressure on them, and then the collapsed capillaries spread to the arteries and the veins, and that's why you have these don't get blood supply to the tissue anymore because they have collapsed, and so the skin starts to die or decay in there, and that's what causes these pressure injuries. So the minute you see any pigmentation change on the outside of your skin, the very second you see it, you have to be off that area. Now, there's just no give and take on this, because if you get a pressure injury, if you get that pigmentation change, that's an early stage 1. That's very early. Stage 2, the top layer of skin is just taken off, so you have an opening. That's an area for bacteria to enter. 3 is deep into the tissue, and 4 goes right down to the bone. So once you have that open area, you're going to have a scar on this outer skin, and you can see how flexible skin is. It's really pretty flexible. If you look at your joints and you see, well, my skin is flat when my joint is extended, but when I bend my joint, look at how flexible that skin is. It just moves right with it. Scars are not flexible. They don't do that. They don't have that elasticity. And so they're far more vulnerable than your regular skin. So you really don't want to have, once the surface of that skin is off, you're going to have a scar, and you really want to avoid that scar. Now, it's very, very difficult. Believe me, I appreciate this more than you'll ever know, because people will say, well, okay, I'm gonna stay off this. I've got pressure injury on my bottom. I'm going to lay in bed. I'm not going to put any pressure on that. Oh, but I'm going to get up just for 5 minutes and brush my teeth. No. And the reason why no to that is because the minute you put any pressure on that, you maybe lay in bed all day, maybe several hours. You get up and brush your teeth for 5 minutes. You put that pressure back on there before those capillaries have healed. and it just negates all that time you spent in bed laying. So you need to really take care of these early. You need to watch and check your skin frequently to make sure you don't get these pressure injuries. I mean, this is really serious business, because if you talk to anyone, and there was a man on my local TV, and he had a pressure injury. He happened to have paralysis. He had a pressure injury, and it got so bad he had to have a surgical correction of that. That sometimes after you have surgical correction, for that area to heal, you sometimes have to lay in bed 9 to 12 months before you can get up again. So you see, if you have to lay in bed a couple of weeks, well, yeah, that's horrible enough, because it interferes with your life so much, but it's better than being in bed for a year. So, and he was on TV warning people about this. It was a wonderful news item. I don't know that many people could relate to that, but boy, I sure could. We have a lot of questions, and I want to get to them all today. So I'm going to go ahead and move into that now that I've done the gloom and doom of pressure injury, but it is a serious business. We have a question from a lady who's 55 years old. She has a T8 spinal cord injury from 2015 from a motor vehicle accident. She says she has very horrible spasms. And she had some kind of drug. She's not sure what it was. And anyway, she stopped taking it. It sounds like it was some kind of weird sort of thing. So the question is, what can she do about these spasms? And spasms, there's kind of a hierarchy. If you gently range of motion, move all the joints, that very slowly, very calmly, because you don't want to stimulate an increase in spasms. But if you very carefully do that, exercise, then that can reduce some of the spasms. If they're very bad spasms, you might need to take oral medications. They work throughout the whole body. If they are really horrible spasms, excuse me, I have a tickle. You might need to get a baclofen pump to reduce the spasms. What most people are doing now is they're taking the Botox injections, and that's working very well. It's locally, it's injections into the area where in just the muscles where that spasming is occurring. And what is happening is that is reducing the spasms. You have to go back and have the Botox injections repeated every so many months to keep it under control, but and that doesn't travel throughout the whole body, so you don't kind of get that brain fog from oral medications like you would. So this would be an opportunity, because she's on baclofen, diazepam, that's probably for the spasms, and she's also taking gabapentin, which is for the pain. And so if that's not working well for you, then try the Botox. And that usually most people can get off the baclofen and the diazepam for that. The gabapentin is for nerve pain. And so sometimes the Botox, if the spasms are causing the nerve pain, sometimes that will take care of it. Sometimes the nerve pain is a separate issue all within itself. So she also has an indwelling catheter because she wasn't taught how to cath. So I would recommend that you, and Chris is going to put up a link for this, but there is a spiral bound book. You can get it online, so it doesn't take long to get it. It's all about paralysis, everything that you need to know about paralysis. It explains how to catheterize, how to do a bowel program, how to transfer, how to go to the movies, how to do this, it explains everything you need to know about paralysis. So that would be a good place to start for that. So this lady also has a recurring UTI, and she's got an indwelling catheter because she doesn't know how to catheterize. So doing intermittent catheterization would help at T8. That would be something. With T8, you'd have good hand function. You'd be able to learn how to catheterize. If you can get a home health person to help you do that, if you can talk to your healthcare professional and go to a therapy session, the therapist can teach you how to, usually the occupational therapist will teach you how to catheterize. If you can get a nurse to do it, they know the ins and outs of that completely. Also, a physical therapist can help you learn to transfer on and off onto the toilet to be able to catheterize. So that is something that you can do. Something else, if you struggle with catheterization being a female, that can be a challenge. It certainly should be manageable at T8. But there's also the mitral fan-off procedure where they put a little they take your appendix and connect the inside of your belly button to your top of your bladder, and you can just catheterize through your belly buttons. That works out real swell too. Another question, is hair loss common? Whenever you have something really critical that's happened to your body, your hair falls out. Not all the way. You hear people who have chemotherapy and their hair falls out. That's from the chemotherapy. But whenever you have a huge stressor in your life, your hair will thin. And so that is not uncommon when you have a spinal cord injury. In men, a lot of hair falls out because of testosterone changes, but it can happen in women too, just from the stress and all that sort of thing. So if you need help in finding a person in Georgia, you can go on to the Christopher and Dana Reeve Paralysis website, and there is a place where you can find help in your local area. There's a little, like a Google search thing that they have on there that will give you, or you can call the Paralysis Resource Center. Chris is on today. You can talk to him, but there are a variety of people there that you can talk to from the Paralysis Resource Center. And they can certainly help you locate somebody. We don't suggest people, we don't say, well, this is the one for you, but you can certainly get a good idea of who might be able to help you with that, with finding somebody who can you really need somebody who can kind of guide you through this whole process. And they can give you all kinds of help with people to help in home health, or, set up with your payer on what kind of services you would be allowed and what kind you would be paying for yourself. And then that she had one more question down here. I'm trying to get my computer to go with it. My computer's kind of jumping around. Okay, another question that somebody, that was all that individual's question. So I hope we answered some. It's kind of like kind of getting starting from rehab from ground zero. Another thing you might want to do also, by the way, is to contact the Peer Mentor program, because they have fabulous people in there that can kind of help you transition, answer some of the day-to-day questions that in your area, so they kind of know the way that, they might be able to hook you up with somebody if say, I don't know if you are or not, but if say you're on Medicaid, that they can kind of help you kind of walk through some of the ins and outs of that. Now, I have a therapist who wrote in and is looking for grant money, and I'm not sure if that's for individual people, because there is just never enough money when you have something as catastrophic as spinal cord injury, brain injury, stroke. There is never enough resources. There just isn't. And I know, speaking as a family member of somebody who had paralysis from disease, and I know from being a nurse and just seeing so many people that you become really close. You work so closely and so long with people with spinal cord injury and head injury and stroke, and the difficulty in getting the resources that you need and the financial support. And I know my bill that I was taking care of was $10,000 a month. For my family member, and just on a wing and a prayer, somehow we made it through all of that. But coming up with, who makes that kind of money? It's just kind of crazy. And so, I really hope that I would just love to get something going in Congress. I've contacted all my Congress people, because, something needs to be done for these healthcare costs. It's just, medications and just everything. It's just skyrocketing. So Linda's ready to testify if we could ever get something like that going. I mean, it happens on occasion. There's so many things going on now. I don't know where that would fit in with I just don't know, but that needs to change. Somebody else wrote in, and and the other thing is, if you are looking for as a therapist for grant money for a project that you want to do to help a variety of people, like if you wanted to start a support group or you wanted to start a particular class for how to do wheelchair mobility, kind of to improve people's mobility, or a wheelchair seating clinic or something, you can apply to the Christopher and Dana Reeve Foundation for quality of life grant support. And so, you'll have to read all the specifications and see about that. But there's a lot of money that's available for groups and organizations that help a broad body of people through the Christopher and Dana Reeve Foundation. Not so much for individuals. I know a lot of individuals, I really need a van. Well, imagine the cost of a van, and you're on this fixed income and your expenses and everything. It's pretty difficult to get stuff like that. So those things usually come from private donors. Some people will have fundraisers. There's Help Hope Live, who help people do fundraisers to get particular items. You have to be careful when if you do a GoFundMe page, because that can work against your Medicaid money, or if you're on some kind of governmental assistance, they then deduct that from your assistance. So you have to be real careful. Help Hope Live helps you raise the money. The money is then funneled through Help Hope Lives. You get your item, but they purchase it. And I'm probably not saying that exactly correctly. I'm sorry, Help Hope Lives, because they've educated me on this so much. But that way you can kind of work around some of those problems. They can help you through all those financial ins and outs. There's a person who has cystitis. It's painful, and she says there's nothing that the urologist can do. Now, cystitis is an inflammation of the bladder. Itis is always an inflammation. And so they're using a lot of Botox injections inserted into the bladder now, which is kind of helpful for that. Some people have chronic infections, and that could be the cause of the cystitis. So it's kind of a trial and effort method to keep going through and see what kinds of things. She's not getting success with her urologist, so try another urologist. Keep trying until they can explain to you what it is that you have and what the treatment would be for you. Sometimes if it's this ongoing pain, it could be neuropathic pain, and maybe something like the gabapentin or the pregabalin might help with that as well. Here's somebody else that has legs that are stiff and tight. What can I do to loosen that? If they're just stiff and tight, try first with a range of motion several times a day. It tires the muscles, so it kind of wears them out, and that stretching helps a lot to reduce a lot of that stiffness. That's like the basic entry level. And then you can go up with medications, Botox injections, those kind of things. There's a person that's written in, their husband's quadriplegic. They have a power chair with a Rojo seat. He has large pink red color skin problems. Sometimes it breaks open, and most of the time not, but it's usually always this discoloration. So that is a pressure injury, that the capillaries are collapsed in there. That's why you get the blood inside the tissue, because the capillaries aren't circulating that blood as they need to. So that's always going to be kind of a danger area, but at least it doesn't break open that often. So that's good. Rojo cushions are excellent. I love them. They're just fabulous. They help everyone. It might be that he might need something at a higher level than a Rojo. Rojo is kind of like the deluxe, but you can also get alternating pressure. You might need to be off of this bottom a few times a day. If he's in the power chair all day and he's just sitting there or reclining in the power chair and laying on his bottom, it might be just too much time in the power chair, and he might need to take some time out of that. So there's several different things you can try there. You can see if he's got this red area that's constantly there, maybe he needs to be off of that for a while until that all heals up. and then start back with seating again, check with your healthcare professional to find out what is the right thing for him to do, because that can be helped. And so, you know, you don't want to live on the edge there, kind of living on the edge of danger. And so we want to get you off of that. So that would be a good thing. And again, there are some people who've had spinal cord injury for a long time. I've been in this area of healthcare for a long time. I've seen a lot of changes in how we take care of these things. And I'm going to bring this up. Don't anybody do this. The minute you say something, then people kind of don't hear the don't do this part and do it. But it used to be that massage the area and that will stimulate blood growth. Think about massaging an area. That's adding pressure. So you don't do anything, don't touch it, don't put any pressure on it, don't lay on it, don't do anything in that regard. It's the area is closed. You just need to stay off of it. This lady her husband has had a T12 paralysis for 9 years, but feel like they're keeping the pressure at bay, but they feel like they need to be more prepared. Keep looking, keep watching, stay ever vigilant for those change in pigmentation. That is the thing to do. Now, if you're thinking that your equipment is not high level enough, you'll need to talk to your healthcare professional to see what kinds of things can be done. If you can get into a standing frame, that gives you time to be off your backside completely. Pretty much everybody can get a standing frame now, which is rather nice. You need to check with your payer. Check to see on the back of your health insurance card, call the number and ask for your case manager. If a case manager has not been assigned to you by your payer, please request one, because that is your link into your insurance. They can kind of help you juggle some of your needs and your finances around within your insurance policy to get some of this equipment. But most payers now will pay for a standing frame, and at T12 that would be possible. If you have RGOs or leg splints that he does some standing, maybe some walking in, sometimes people get those. Holding up your body when you don't have sensation in the lower part of your body is a challenge. It's hard, it's difficult. Holding up your whole weight of your body with your arms is a challenge. But if you can do that, so sometimes people get splints for walking or equipment for walking, but it's so difficult, they kind of give it up. So use it for exercise. If you can't use it, you know, to get around, use it for exercise. Be sure you have pressure dispersing equipment on the bed, on the chair, wherever he's sitting. Move it. If you're moving to a desk chair, move that equipment with you. If you're on the airplane, take that equipment with you. We used to take my husband's, we called it his cushion, and I had it in a big tote bag that I made for it, because no tote bag's big enough for those. And so we just, put it around my shoulder there, and we go with the cushion, and no matter where we went, a restaurant or wherever, and he was able to sit on his little cushion there. And that was very helpful. Now, there's several people that have written in with problem with their bowels. So I'm going to be writing the month of July all about bowels and rethinking about your bowels. There are several things that people have bowel problems, and the bowel slows down because it's not getting the message. If you have a neurogenic bowel, the bowel still works, but it's slow. It's not getting that full message to move waste along. So some of the things that I see that people have problems with their bowels is, first, if they use a suppository, they don't put it up against the bowel wall. People want to put that suppository in, they just stick it in there, they get in, they get out, they're done. But if you put that suppository in the middle of a pack of stool, it's not going to have the body heat to dissolve the suppository. It's got to go against the bowel wall where your body heat can dissolve it. Some people have a difficulty with suppository. They can try a mini enema. You don't want to use a full enema because that flushes out the bowel, and then that slows the bowel from working even further. Some people don't eat enough roughage. We always say to people, this is another change that has gone on recently, is to add fiber to your diet. If you add it through food, great. If you take one of the fiber supplements like Metamucil, you have to drink the amount of water that goes with that. Otherwise, you're creating a rock in your bowel and you're making it worse. So I have seen people in the hospital, here's your Metamucil, and they put it in that 30 cc medicine cup. You know, it's like this big around, and it's like this big. And they put the Metamucil in there, and then they put the water into the top of the cup and they stir it up. Here you go, because it's with water. No, it has to be the full complement of water. It has to be like 6 or 8 ounces. You might not be able to drink that much in one setting if you're on a bladder management program. So we're saying don't do the fiber medication anymore. Get the roughage through your diet, beans, green leafies. If you're not on an anticoagulant, you know, get that fiber going in on your diet. Drink fluids, because the longer that waste is in your body, the bowel is still working with drawing fluid, but now it's going through slower. So the stool gets drier and drier and drier, and it's like a rock when it is time to come out. So drink fluid as much as your bladder management program will allow. Possibilities for increasing uptime for those who have multiple flap surgeries. I have to say, talk to your surgeon about that. Each surgery is different. If they've rotated a muscle flap in there, or if they've just rotated skin over the top, it's different. A muscle flap will give you more cushion in your body. Sometimes they'll move that muscle flap to put cushion over that bony area. Sometimes they just close them with skin, but usually it's a muscle flap. That all has to heal. So, and as I say, it can take up to a year. So talk to your surgeon about when you can increase your uptime. And then you have to do it very slowly, no more than even 5 minutes at a time, maybe even less. Then you have to get off of it and check it and be off of it for a couple hours. So talk to your surgeon. Once you've had that surgery, it is a long process. You will get back to sitting. There's no question that, but remember, now you have scars from your surgery. So that area is not elastic like the rest of your skin. It's very susceptible to breaking open again. So you don't want to push it too fast. You have to be very cautious of this sort of thing. Okay. This is a very interesting question about the relation of the vagus nerve and spinal cord injury. And I wrote a blog about the vagus nerve. But the vagus nerve is a very interesting nerve because it's a big, long nerve, and it comes out at several different places in the spinal cord, and it does a lot of things. So the vagus nerve can be injured at various points, or it can be injured lower, but maybe have effects higher, because sometimes the effects of the nerve are higher than where your injury level is. But the vagus nerve does a lot of things. So it controls your throat and swallowing up high. It controls your stomach digestion. It controls your bowel digestion. It controls toileting. It has some input in toiling, both bowel and bladder. It also appears to affect your mood. It controls your heart, controls your lungs. It does a lot of things. It's a very busy nerve. It's a very long nerve, and it's a very busy nerve. So the vagus nerve is affected by spinal cord injury depending on where the injury is, but it can also affect higher up than where your level of injury is. So the vagus nerve is from the parasympathetic nervous system. So you have your nervous system. It has a parasympathetic side and it has the sympathetic side. Now we talk a lot about the sympathetic side, because that's where autonomic dysreflexia is a big source. We talk about that. That's the fight or flight. That's like when the autonomic nervous system goes. That's a subset of the sympathetic nervous system. It's like in full charge, or it's, you know, just kind of hanging there. The sympathetic, parasympathetic nervous system is what we call rest and digest. They kind of balance each other out. So the vagus nerve is going to want to slow things down, slow your heart down, slow your bowel down. So it kind of just wants to keep everything going, but just kind of take its own little time. So sometimes you need to speed things up, like when your bowel works, you want to get that moving. So sometimes you want to speed that up. And if the vagus nerve is affected, that's why things are so slowly moving. Let's see. Oh, how can a quadriplegic lose weight with limited access to cardio? I did a wonderful interview with Dr. David Gator of the Miami Project, who has spent his career studying metabolism. And so he says, for right now, calories in versus calories out. Be sure and talk to a nutritionist about how many calories you need, what type of calories, proteins, carbohydrates, all of that, and get a good diet plan for yourself, because it's going to be a little different for everybody. The amount of energy expenditure as a quadriplegic that you're using is not going to be it's not going to be the same high amount as somebody who's moving around. Not the same as somebody who's out running marathons or whatever, but we're not necessarily interested in that. But right now it's calories in versus calories out, but you need to know what your energy expenditure is. And he has a formula for figuring it out. But if you talk to a nutritionist that works with people, call your healthcare professional, ask for a dietary consult. You usually get one a year. And see if you can talk to a nutritionist or a dietitian about calculating your calories and what you as an individual, because let's face it, we're all unique. So talk to that person to see what you can do. Here's a mother of a son who's 4 years, 10 months. He has a C3 and C5 injury and spasticity, and she wants to know how to manage his spasticity. And actually, you can do medications. You can do the range of motion. Actually, the Botox was accepted in the pediatric population as medical treatment earlier than it was in the adult situation, so in the adult population. So Botox is given a lot to children who have spasticity, and that can really help. He knows when he has to go to the bathroom, and that's a good thing. And so he can type and use his hands. So he's got a lot of good things going on, but be sure and check into maybe Botox, maybe medications. If it's just in his legs, he sounds like he has pretty good function in his hands. So the Botox works more locally. I'm not, and I sound like I'm advocating Botox. I don't advocate anything, but it just seems to me like that would be the simplest thing and the least invasive kind of thing for him. Now, at children getting multiple shots over multiple periods of time, that can be quite alarming. In the pediatric setting, they do have child life specialists that are professionals at distracting children. And I know from a recent fracture of my granddaughter's pinky finger, and the child life specialist came and they did a lot of distraction with that. And it was a very successful, I know from working in pediatrics, wonderful group of professionals. They know what they're doing and they will really help you. I wish they had child life specialists to distract the children, and then child life specialists to distract the parents and grandmas who are like, oh, my baby, what's going on? So they don't have that. We have to be adult, but they do have that. So that's very helpful. So you can kind of allay some of your fears about doing that. Are there any new innovation for treatments of incontinence other than potty training? This person has a T10 incomplete paraplegic with a neurogenic bladder. Well, the treatment for neurogenic bladder is intermittent catheterization at the T10 level. Now, some people, they don't want to catheterize. Oh, it's awkward and but you get used to it. It becomes your new normal. And you have to keep at it. You have to keep practicing with it. Now, we don't call it potty training because it's not like children. It's not like, if you go, children are potty trained because their nerves are developing And so you're training them to recognize when they need to go potty and to go in there in time, not to be distracted by play, but when you need to go potty, to get up and go potty. So we call it bladder programs because you have to just do it on a systematic time. I talked about the mitral fan off, if that is more pleasing. I'm not, surgery is always a risk for anybody with neurological injury. Surgery is a risk for anybody. It's a higher risk if you have neurological surgery. So you don't want to jump right into that. But right now, intermittent catheter at the T10 level would be the thing that would be done. Some people who have lower level injuries are able to do some reflex arc strategies with their bladder, and so they're able to stimulate a void, but at T10 that's probably not going to be an option. So intermittent catheterization with neurogenic bladder, unlike a child that's learning to develop their nerves, the neurogenic bladder, the nerves are not working. So you have to be able to go on a time basis. And that's really what we want to do. We want to do with bowel and bladder. We want to control and contain. You don't want to be having accidents. You don't want to be perhaps wearing a diaper if you don't have to, but control and contain. And it's totally possible. And it's really pretty, I'm not going to say it's simple, because when it's you and you have to do it, it's not simple. But these are the kinds of things that need to be done. So this is just the way it is. There's a variety of catheters, which makes it very easy. There's shorter ones for women. There's pre-lubricated catheters. Now it depends on what your payer will pay for. So those are all different sorts of issues. But get started with that, because that's pretty much the only way that you're going to be able to control and contain your urine. If you don't catheterize, you don't catheterize in time, and the internal sphincter doesn't open, so you never void, it just stays in your bladder. It's going to back up into your kidneys and you're going to lose your kidneys. So it's important that you catheterize on a timely basis. Have a urodynamics test done to see if there's any medication, if you need more forceful bladder muscle contraction, if you need something for the opening to the bladder, the sphincters, check to make sure that everything's in good working order, and keep up with that yearly. If you go and there's no problem, check it off and say, hallelujah, there's no problem. But don't skip your annual visit to the urologist, because people will be great. A year has gone by, great. 5 years has gone by, 10, 20, no problem, no problem. And people are like, I'm tired of this. I'm not doing this anymore. Year 21, all of a sudden there's a problem. That's the way it comes. It comes all of a sudden, and you don't know it until it's there. So be sure and have your annual checkup there. Okay, here's a person that's been a 4 or 5 quads since 1983. He's generally good health. At age 60, 39 in the chair. Is there technology available for old quad bodies to relieve pain from wear and tear besides painkillers? I found a study from the University of Washington that shows a high number of quadriplegics break their arm near the shoulder, probably from how we maneuver. Yes, shoulder dislocation, torn rotator cuff. Yes, it's a huge problem, and it's from a couple of issues. It's because people want to move so fast, they put their arms way back, grab those wheels, and that really overdoes the shoulders. Also, pushing up and moving your body really overdoes the shoulders. So what we recommend is that when you push your wheelchair, if you're doing that manually, just go from your arms straight down from your shoulders, straight down. Don't pull it back so far, just straight down, and then just go for it. You have to take more little pushes, but you can still go just as fast. And once you build up speed and you don't have so much strain. So that's a hard technique. If you've been pushing way back, that's a hard technique. When you get to be 60 and you get to be older and you've been transferring your body, that's a lot of strain on those shoulders. Talk to your doctor about equipment that's available to help you move. There's some transfer equipment. Now, you may go out to a restaurant and you can't bring your standing transfer frame or whatever to the restaurant, you can still transfer and do what you want. But when you're at home, maybe for getting in the shower, getting in and out of your chair, getting in and out of bed, you can use this transfer equipment, and that certainly helps. Some people will go back to using a sliding board to take some of the weight off of their shoulders. So there's all kinds of things that you can do to help relieve that. But I'm glad you asked about that, because that's a pretty important question for what we need to do to keep that healthy. And then there's a person that wrote in and says, every once in a while I get a shiver and it's so bad I can't stop, no fever. So the question would be, is the shiver just like muscle spasm, like, ooh, you know, sometimes people have a little shudder or something, and, you know, it's a perfectly normal thing. So it might have nothing to do with the spinal cord injury at all. Sometimes it's a sign of autonomic dysreflexia. So you'll want to get the AD card that's available. It's a wallet card. It's available. There's several wallet cards available from the Christopher and Dana Reeve Foundation. Everything from there is free. It's freely given information. You can download it off the website. It's all about autonomic dysreflexia. There's one on sepsis and there's one on deep vein thrombosis. They're emergency conditions that you need to know the ins and outs of. People know about autonomic dysreflexia and they've learned, oh, the main symptom is this big pounding headache, and I don't have that, so I don't have AD. Maybe you do. There's a lot of other little symptoms like spasms or stuffy nose or a rash, all kinds of little things that can come up. So get that card so you can be looking, check your blood pressure. If you have that shiver, check your blood pressure to make sure you're not having an autonomic dysreflexic episode. There's also silent AD. Maybe you're having silent AD. So check your blood pressure just occasionally, now and again, when you're doing activities like in the middle of your bowel program. Or maybe you have no symptoms, it's silent AD, you have no symptoms at all, but you have the blood pressure changes. So check and see if you are having maybe autonomic dysreflexia. Somebody else wrote in about suprapubic calf tunneling. It's a possibility. Sometimes you get a little blind pocket, a little fistula that goes off on that. You can have that checked during your office visit. You can have that your regular physician visit. You can have that checked at your urodynamic testing if you have a urologist. If you're having urodynamic testing, you may not need that. If you have a suprapubic, you know, it just all depends on what your usual bladder care is. If you talk to your regular physician and they say you need to go see a urologist, be sure and have that checked out, because that can be a source of infection, or it can be a fistula into your bowel. It can end up to be a lot of different problems. So you want to be sure and have that corrected right away. Bowel care, digital stimulation versus other options. Basically, that's what bowel care is inserting that suppository up against the wall and then doing the digital stimulation. Nobody likes it, but people get accustomed to it. When you do your digital stimulation, be sure you do it very, very gently. Again, people want to get in and get out, and they do that digital stimulation. And what they're doing is triggering spasticity in their bowel, and it closes the bowel even more tightly closed at the sphincter, even more tightly closed in the lower bowel. So do it very gently. Be sure and use a generous amount of lubricant. This is not a time to skimp on that. Sometimes people put a bit on their finger and they, oh yeah, it's going to spread all the way up. Well, if it's just a little tiny drop, think about it. It's not going to spread over that whole gloved finger. So use a generous amount of lubricant, because you don't want to develop hemorrhoids or rip that delicate bowel tissue. So digital stimulation is the thing to use. Even with the mini enemas, sometimes digital stimulation needs to be used, but you can try a mini enema and see how that works. There's a question about somebody wanted to learn about using the Pristine enema balloon, and that is also another option. There's there's a difference of opinion. There's people who get that system. It's more expensive than using the suppository or even the mini enema, so you have to apply to get it. It can be a challenge to get it, but the company will help work that through with you. Sometimes people get it and they just never get the hang of it. And so there are people who have it and love it. There are people who have it, not so much success with it. But the company is there and they're ready to help you. I've been to some sessions on it, particularly to learn some tips on how to make it work. So it's not, I don't want to say it's not intuitive. The instructions are very clear, but there's some little tips and tricks to use to make it work. Again, you can call the company and they have nurses there that will walk you through that. So, don't just try it and be like, this didn't work. No, you have to be able to hook it up just right. And you have to be able to, there are little things that you have to do with it that once you see it, it's like, oh, well, of course. But, maybe until somebody points that out to you, maybe it's not quite so intuitive. But there are people who love it. There are people who, just kind of never get the hang of it. But I don't think that they really gave it maybe the full try or went to the effort of calling people and asking for help. So with that, there's going to be a lot more coming up about bowel. This month was skin. Next week's going to be bowels. So we'll look forward to that next month, and I look forward to seeing you in July. Thanks for attending.